Hello, everyone. Welcome to our Nesta Talks 2 event. We're very excited to have you here today. So today we're going to be looking at how racism impacts our health with Dr. Onye Nnorom. So I am Parita Doshi, the Deputy Director for our Healthy Life mission at Nesta. And we're delighted to be joined today with Dr. Onye Nnorom, who's actually joining from Canada. So she's gotten up very early to be with us here today. Who I will give you a little bit of a brief overview to, and she'll also tell us a little bit more about herself. But Dr. Onye Nnorom is a family doctor and public health specialist. Her work focuses on health equity and how racism impacts our health, and in particular on anti-Black racism as a driver of these inequities in Canada. So she's really passionate about this subject, having experienced kind of racism herself at a very young age. But she also wears lots of different hats. So she works at the University of Toronto. She's the Black Health Theme Lead, the EDI Lead, the Associate Program Director of Public Health and Preventative Medicine Residency Program. She is also the President of the Black Physicians Association of Ontario, a clinical consultant on addiction and mental health, and also the host of a wonderful podcast, which you should all check out after this if you've not already, called Race, Health and Happiness. So thank you for joining us today, Dr. Nnorom. I will just start first by giving a little bit of an overview of the structure of the session for the audience, and then give a bit of an intro into kind of why we picked this topic at Nesta. And then we'll really be hearing a lot more from you in terms of, exploring this topic together. So we'll talk a little bit about, the kind of structure will be, we'll do a bit of an intro from yourself for about 5 minutes. We'll have 20 minutes of questions where I can kind of ask a few of the questions and we can have a conversation. We will then move over to you, the audience, for 20 to 25 minutes of questions. So please do enter your questions into the chat. We will be kind of looking at those and picking up on some of those. So we really want this to be a kind of collaborative discussion. So please do enter that in, and also let us know where you're calling in from. It's always really nice to hear who you are, who we've got in this virtual room, and where you're calling from. So please, I encourage you to kind of to connect with that. So that's just a little bit of the housekeeping. I will tell you a bit about Nesta and why we've picked this topic, and then I promise you I will hand you over to Dr. Nnorom. But so at Nesta, we've got a healthy life mission, and our mission is to increase the average number of healthy years lived in the UK while narrowing health inequalities. And the kind of two areas that we're focusing more of our work on one is around promoting healthy eating and reducing obesity, and the second is around loneliness. And both of these areas contribute to some of the greatest losses of healthy life in the UK and also more broadly in other parts of the world. But we also know that there's a disproportionate impact of this ill health on different groups, including kind of different ethnicities. And just to kind of tell you a little bit more about the picture in the UK in terms of obesity, Black adults were kind of about 68% of Black adults were overweight or obese in the UK versus 63% on average. So there's kind of a higher kind of instance there, but also just more generally across different ethnicities. We've had some research in the UK with nearly 1.4 million over 55s. And it showed that belonging to certain ethnic minority groups is equivalent to being 20 years older than your actual age. And, this is accompanied by, let's say, long-term conditions or multi-morbidity. It could be due to poor experiences of primary care, insufficient support from local services, low patient self-confidence, lots of different factors, which, Dr. Nnorom will talk us through a lot more and we'll be able to shed more light on how we can kind of improve upon. But, there is this impact. And with COVID, it's really clear to all of us that, the kind of disparities. So some groups have up to 5 times greater chance of dying from COVID than other groups. So, we want to understand this and we want to be able to improve this and create a more equitable kind of healthcare system and kind of happier lives for all of us. And at Nesta, really, our mission is to design, test and scale solutions around this and really try and bring in that inclusion as what we do. So very excited to have you with us today to talk about that. So I'm going to start just really by asking you, Dr. Onye, to give a bit of a 5-minute intro to yourself and your work. I know I gave a little bit of a snapshot, but yeah, would love to hear more directly from you.
Yes, thank you so much for having me. And so, yeah, so my work it really focuses on the impacts of racism and different forms of inequities. So I do look beyond issues of racism itself, but poverty and other marginalized groups, that type of thing. But over here in Canada, we have a specialty of medicine called public health and preventive medicine. Many of us in this field are also family doctors at the same time, so we're double certified. And basically, as you mentioned, I hold a number of hats, but it's largely involved doing clinical work in Black communities and looking at, cancer prevention, chronic disease prevention, and looking at methods that work. And then we might publish on it. We don't even publish on everything. It's actually about doing the doing and having an impact. That is my passion, not so much the research, but we do publish, whenever possible. Another piece of my work is training physicians who enter the field of public health and preventive medicine. So some of them do become medical officers of health or medical health officers. I believe you folks have similar roles in the UK, although it can be held by non-physicians. I think in the UK, in Canada, it's only held by physicians. And then quite a bit of my other work really focuses on Black health, specifically as the Black health team lead for the medical school and teaching around issues of Black health and having people understand that the disparities that they either see or have learned about or might be hearing that are happening in the US or the UK, basically the Western world in general, are due to systemic racism. And when we're talking about the Black population, then, specifically anti-Black racism, but broadly talking about how that impacts people's health, physiologically, as far as mental health and things like that. And I would have to say that, I think prior to the pandemic and prior to the unfortunate murder, public murder of George Floyd, and the uprising around Black Lives Matter and activism across the globe that occurred, prior to that, prior to 2020, I think a lot of people struggled to understand how racism impacted health. Either people thought the disparities, like what you're describing, obesity or diabetes. I think most people are aware of racial disparities across the UK, the US. We don't have great data in Canada, but overall we know they're here in Canada, and thought these to be biological differences, which fits within that racist construct that Black and other racialized groups are somehow genetically inferior. So it's kind of like, well, that was just meant to be. And all of you are dying, and it was, determined by God. I think the COVID-19 pandemic and the advocacy made people really pay attention to this issue and understand that it's social factors, that it's not a matter of genetics per se, but it actually is the social conditions in which we live, and the fact that we live in societies where your race determines so much of your outcome creates an extra layer of stress, right? We know living in the US, the UK, Canada, that's stressful. Life is stressful, but an extra layer of stress that leads to premature conditions and premature death within populations. And so I think that has actually made it much easier to have these conversations, because I think people are seeing how that really plays out concretely in real life. So that's my work. But I would say in the last couple of years, unfortunately, we've been in a pandemic for a couple of years. This issue has become much more apparent. And I love that we're meeting today, because not only do we get to talk about the issue, but also explore solutions.
Fab. Yeah, thank you so much. And totally resonate with much of what you just kind of kick us off. Maybe we'll start understanding the problem a little bit more from your perspective, and then we can maybe start looking at some of those solutions that you said that we can talk about. But could you just paint a bit more of a picture for us on, like, what does that systemic inequity and inequality look like within the healthcare system? Yeah.
Okay. So Well, there's two parts to that, because our health outcomes are not actually determined by the healthcare system. The healthcare system is like the mechanic where we go to get things fixed when something's already gone wrong, right? So our health is actually determined by the social determinants of health, where we live, where we work, where we play, how we gather, how we eat, all of those things. And so it's more of our social condition actually that determines our health. And then we enter healthcare to seek, care when care is not optimal. And so if we're going to talk about our society and social systems, we have to talk about how racism as a structure. So when I talk about racism, or when those of us who work in this field, we're not talking about so much the interpersonal racism. That's part of it, how one person treats or behaves to another person. But we more describe that as a symptom of a greater disease. And that's the structural racism. And that's how our policies, our practices, our work cultures, our society's culture continues over time. And you'll see it in again, US, UK, Canada, for example, to systematically disadvantage certain groups and systematically advantage, right? Certain groups, particularly people of white European descent, end up experiencing privilege and better outcomes over and over, and that recreates itself. And you tend to see other groups, and I'll focus on Blacks, but certainly racialized groups, experiencing disparities over and over. So, healthcare, you mentioned healthcare is just one system, but whether we're talking about the judicial system, the educational system, because as one of our scholars here, Dr. Kwame McKenzie, and he worked in the UK as well, describes, it's an ecological phenomenon, right? So this structural racism is everywhere because it was built into the system. Unless you're actively doing something to undo it, it's just there, right? And it just continues to recreate itself. You don't have to intentionally go out and act on it. It's already built into the system. So where you have that, then we talk about what are the health impacts of that? How does that play out? So what that means is that, again, in these countries, what we see is that poverty is racialized. And in capitalist countries, of course, income or poverty is the greatest social determinant of health, right? So we talk about race, but poverty is racialized. So if you're racialized, you're more likely to be poor, and that is likely to impact your health. But then there's also just the legacy of stereotypes about our different groups that also play out in ability to get jobs, what happens in the classroom, how the police make decisions, all of those things. When you walk into healthcare and you say, I'm experiencing, particularly as a Black woman, I had 2 children, right? Like, I'm experiencing pain, I'm pregnant, and that being completely underestimated, right? Because of the stereotype that comes through slavery that Black people have a higher pain threshold, or that women are histrionic. You put both of those together around anti-Black racism, and then gender assumptions about pain and people overreacting, and you end up with a pattern where Black women have much worse outcomes during childbirth and pregnancy. So there's all of these different ways in which the stereotypes also play out and result in poorer outcomes. But the way that I kind of concretely say, so these experiences of these barriers and these daily indignities, the microaggressions, all of that, it happens on kind of 2 levels. And I would say it might be similar in the UK and Canada, more so than the US, because of immigrant populations being more likely to be racialized. So what you will see is that for groups that are aware, so let's say you're born in the UK or you're born in Canada, you grow up here, you've been racialized from the beginning. You enter the classroom, you're racialized from the beginning, you're labeled, assumptions made about you, you've internalized that, you're experiencing it. It's a form of trauma, right? It's a form of trauma. I've experienced, even with white colleagues, just calling them white people, they feel it's jarring, let alone that happening to a young child, right? You've been labeled. And so it's an extra layer of stress. And as this happens over and over and over again, where were you born? What are your credentials? You know what I mean? Like, all of these things, this constant indignities, then result in people having a number of different mental health issues, sometimes depression, anxiety. Cops go by, police go by, and you're hyper vigilant, right? Almost like a PTSD, trying to cope with that stress with overeating or drugs or alcohol or just the everyday stress of racism is not going to have you go for a jog or have a salad. Like you're going to have that hamburger and go to sleep, right? So it's going to affect your habits, and that's going to lead to poorer health outcomes. It's also going to make you more hesitant to seek healthcare. It's also going to make you have a distrust of a vaccine where government says your group is a priority. Your group has never been a priority before, but now that we have this thing to inject into your body, you're a priority. So all of that will result in poor health outcomes because you're aware of the systemic racism. Then we have the kind of general social determinants of health, which is more less prevalent, less obvious sometimes to people who've immigrated from a country. So now you're perhaps an adult or a teenager. You didn't experience racialization as a child. And so you actually have a sense of self, which is protective. And helpful. So you might not be traumatized by all those questions like, where are you from? Or whatever, the cops go by, whatever, you're happy to be in this new country. But what you come to realize is you have to work, people say twice as hard. I would say often 10 times as hard. In Canada, a Black woman is 50% more likely to be overqualified for her job. So your work, it's common with racialized and immigrant communities. You're 3 jobs, whatever. You're just sprinting. You're too tired for your children. You're just doing all of this, trying to catch up, not always realizing that it's because of your race, but that is stress itself. So I would say to some of my patients, even if you don't know what systemic racism is, because some people don't know, they think of racism, nobody said anything mean. But if you don't know what systemic racism is, physiologically, systemic racism knows you because you have that added stress, right? That negative stress or distress that is happening to you that also impacts your health. And you're more likely to be living in poverty. If you're not working 3 times as hard, then you're more likely to just be in a lower income job and struggling and can't afford the food you need, can't afford whatever your resources might be for your level of education. And so that has an impact on health. And I would say the COVID-19 pandemic compounded all of that. Because if you're working in a lower income situation, you're probably an essential worker. You're probably, it might be a taxi driver, or working. In fact, like you're in jobs where you don't have time off, paid leave, you don't have benefits. You might be living in overcrowded housing, like all of the things that COVID-19 just loves to hug and take people down with. Those are probably, either part of your life or your family's life, right? And we have to consider the broader context, your friends, your family, because you're racialized. And again, that distrust of vaccine, that distrust, specifically of the COVID-19 vaccine, all of those then leading to much, much worse outcomes. You'll see in all 3 countries in the context of COVID-19. So it really amplified everything that had existed previously.
Yeah. No, I think it's really interesting what you mentioned about, like, whether you've lived in a country and grown up there or whether you've come, even if you recognize it or not, it's there's a lot of these, subconscious things that kind of happen that actually tangibly make a difference to our physical and mental health. And I think, do you feel like with the pandemic and more of I guess, exposing some of this a little bit more, have you seen kind of any shifts either in kind of individuals recognizing it more and being able to kind of, I don't know, action on it, or even institutions, or more generally, kind of what's been your sense of, has there been also obviously following the BLM movements and things, have you noticed some sorts of shifts, either positive or kind of negative as a result?
So yes, on awareness, less so on action, which I would have to say, I'm going to be very frank, it really did break my heart that I didn't see the level of action I would have imagined. Like I said, I've been doing this work, and actually, even from elementary school, I was one of those kids speaking about racism and apartheid, right? So, this has been an area that I've spoken about for a long time and done the research. And so here in Canada, there was this myth of the multicultural society and we don't have racism here. So that was a barrier that we were trying to overcome. And we don't have the kind of data that you folks have. So for instance, I know there you're able to, since the 90s, really kind of identify disparities. In the United States, they've been able to do that for a long time. So I think here in Canada, we kept thinking if we had the data. And so when COVID-19 began, we really advocated. So, part of the community groups really advocating for the collection of race-based data, which was quite controversial here. And we were able to, say, look, so it was collected particularly in certain pockets of Ontario and I think in Manitoba, so not right across the country, but able to say, look, Black people are, and racialized people are disproportionately impacted. So now action has to be taken. And so yes, there was more awareness, especially with the protests and everything that happened, but what we saw in Canada was really mobilization of resources did not match the data, right? Like you would think things are data informed as far as decision makings. So where test kits, testing, not test kits that came over, but just initial testing, we saw a similar pattern here in Canada than in the United States, where it really went to more affluent areas first. So, clinics were set up in affluent areas to do testing for COVID-19. When people came from other neighborhoods, they were turned away. Later on, Black and racialized neighborhoods got it, but the lineup would then be almost half of the people who are not from those neighborhoods, right? Like that sense that we can't go to your neighborhood, but now that we have testing, you're here in our neighborhood, and we, generally don't turn people away. Then when it came to vaccine, it was the same thing. Vaccines were more available in affluent neighborhoods. And then just very more recently, now that we have rapid tests, again, that happened, particularly in Ontario. So, I mean, I had always said that the collection of race-based data is necessary, but not sufficient for change. I had always said that. But to see it play out in a pandemic that way, over and over, and lives lost, reports here stating that, if the deaths that happened in racialized communities had happened in white communities at that rate, something would have been done. And that's like, a Royal Commission report. It's like, those are real people's lives. Those are moms who are, personal support workers and nurses and service workers who died unnecessarily because there wasn't a willingness to basically recognize our humanity because of what we call skin phenotype, right? Like you just happen to have different skin color. It's absurd and scary and saddens me. But I still have hope because there still is that awareness. And so what many of us who are in the margins, who are Black and racialized, what we've been able to do with this pandemic is mobilize some resources and engage in clinics and outreach that has made a difference. And so I don't know that would have happened outside of the pandemic, of groups realizing, okay, we need to give you folks some resources to go out in community and make an impact. So that gives me hope. But I would have expected a greater, or wanted a greater shift that would have actually saved lives internationally, really, if that lens had been used.
Yeah, no, totally share that. My family lives in Kenya, and I think I was spent quite many months in there last year, and I think just seeing even the access to vaccines, the difference in the UK had it been there versus in a different country. And I think, as you say, like there's just so many examples that we've all kind of experienced or felt as a result of this pandemic that hopefully I share that hope that that awareness is a starting point, and we can really build on that and work together to kind of mobilize that change. So kind of looking to some of the work that you've done or you've seen, or thinking about how we can move this forward, what might be some of these kind of anti-racist approaches or changes that you feel we should be making? What are some of the top things kind of on your mind that we can do in order to kind of start shifting that balance and bringing more equity to things?
Yeah, so I think there's a number of things that can be done. And, I would, I think there was a comment earlier for literature. So there's a really great article actually from the UK and the British Medical Journal on COVID-19 and racism. I think it was January 2021 that I think it's Mohammed Osai, but really great kind of policy recommendations there. I know there was a great BBC documentary on why is COVID killing people of color. Like there's, there's all of those pieces that I would actually recommend people look at. But nonetheless, I think that there's kind of two areas. Like we talked about health and healthcare. So broadly for health, if we want to like have an impact on health, then you're thinking about the social issues. So that becomes, you know, a matter of policy and how people vote, and thinking about more, you know, equitable approaches to, you know, education system, judicial system, healthcare system, all of that. So there's the big pieces, and looking at that and how you vote. Nobody ever wants to say how you vote, but that is health, period. But if you want to kind of zoom in concretely on healthcare, then it becomes looking at leadership, honestly, right? Even where I say we've been able to make advances with regards to, you know, mobilizing resources and working in the community, we've had different public health leaders here in Ontario who some, I'm not going to get specific and name names, but, you know, we're just like, you know, we don't need to collect race-based data and racism is not an issue, versus, oh no, this is an issue. Let's make sure this happens. So I think there is that need to make sure with regards to leadership that they have either that anti-oppression training or understand these issues, or have that embedded in the leadership. And so to have that, those voices, you really need diversity there. And I know with Nesta Talks, you folks had a video recently with, you know, I can't remember the name of the company, but, you know, a woman really kind of offering entrepreneurship and other opportunities to diverse groups, right? And saying, like, if we're going to solve the problems of the future, you know, the problems of the future involve all of us. And so all of us have to be part of the solutions. So you do need that. You need these voices at the table. And I'll give you a concrete example. At the beginning of the pandemic here, so for us, it started in basically like we were about to go into lockdown in March 2020. For us here, and I think it was happening internationally, there was this rhetoric around COVID-19 being the great equalizer. Our Black community leaders published a commentary or a position statement saying it is not the great equalizer. And in fact, Black and racialized communities are going to be disproportionately impacted, particularly racialized women working, again, like as PSWs and all of these different service positions are going to be disproportionately impacted, and it's going to devastate our communities. We need collection of race-based data, and we need a different approach. They released that April 2nd. So we just, as soon as we went into lockdown, they're writing this, it goes out April 2nd, 2020. Nobody paid attention to it because they're not at the table. I'm not at the table. You know what I mean? Like none of us who are racialized or have our, you know, our finger on the pulse of what's happening on the ground are at the table. And so lots of time went by and was wasted, and lives were wasted because our voices are not, you know, equally heard, and our lives are not equally valued is really what it comes down to. Had those you know, those leaders been able to be at the tables, I think their approaches and their innovative lens would have helped with a lot of the problem solving that we all just went downhill with, because it was only people of privilege who can't see everything that that is happening on the ground. It's not their lived experience. It's in fact not their fault, but it's having the self-awareness to know as a person of privilege, particularly if you're a white, cisgender, Christian, middle-class male, all of your many blind spots in being able to address the diverse community. And so we ended up in a disaster. And so that is really necessary to have those voices at the table. It's also necessary that we move away from just looking at the Western medical model. And so for us, again, another concrete example, prior to the pandemic, I worked at a community health center called Taibu Community Health Center. It has a mandate to serve the Black community in the Greater Toronto area, as well as the very diverse community. So, you know, our South Asian communities, our Indigenous communities, so just very, very diverse community in that area. And what we would have is we would have, you know, people come in. I had patients come in who had diabetes, hypertension, all of these things, but we had dietitians who were from diverse backgrounds who could like have the cultural dexterity to like change up the recipes so that they were heart healthy, create community. So there was a community kitchen and everybody would come together of diverse, you know, backgrounds and try to cook, you know, the new heart healthy meal, right? Sometimes it wasn't so great tasting, but other times it was fantastic and people would go home and cook that with their families. But just that sense of togetherness. There would be laughter yoga, there would be African dance, there would be all of these things. And I saw people get better. I mainly was involved in de-prescribing. I was reducing their medications because they were getting better, not just getting better with regards to diabetes and hypertension, but even chronic pain, because they came together in what we call the spirit of Ubuntu. I am because we are. And then we applied that to cancer screening, and we saw, we had cancer screening rates very low. People weren't, were hesitant to get their cancer screening for mammography, pap test, all of that. We asked them, we listened, we said, what are the issues? What are you worried about? Non-judgmental, because it's that I am because we are, that village model. Based on that, we addressed their concerns, and we tripled our mammography rates. We, increased, also tripled colon cancer screening. And then we did the same thing with flu vaccine. And so when COVID-19 hit, we said, let's use the same Afrocentric model. So where we have clinics, so for the Black Physicians Association of Ontario, we collaborate with Black community organizations that have trust. We still work with the hospitals and public health, but we explain to them that it's the legacy of anti-Black racism, mistreatment, or just being ignored and neglected that has impacted trust. So they need to do better, but they can come with us and learn. And then we come together. And so we're able to, have a vaccine clinic where there's music and there's food and there's things for your children. And this was even before we were vaccinating children, because we care about you as a person. It's not just about the vaccine. And if you don't want the vaccine, it's okay, because I still care about you. We love you. We want to embrace you. We're going to talk about it, and you can go home and think about it. And then, I'm going to look you in the eye, unlike some of the other vaccine clinics, and I'm going to ask you, how are you? I'm going to answer your questions, give you the vaccine, and celebrate you, and tell you, yes, you got your vaccine. We celebrate you. And you go home and you tell your family about it, and we wish you well. And, people started to call that public health 2.0. But what that was combining the Western lens with an Afrocentric lens. And as I answer this question, I also want to give credit and respect to our Indigenous communities, because it's their model around cultural safety, about that humility of listening, and how they set up their clinics, that they joined with us in solidarity for the design of our clinics. So it's a concept called two-eyed seeing. And I think that also can address your question as well. The concept of two-eyed seeing is comes from an Indigenous nation here called the Mi'kmaq. And it's really seeing the best of the Western world and the best of Indigenous approaches and combining the two. I would say for us, coming from an Afrocentric model, it was almost like HG, you know what I mean? Because we borrowed from Indigenous ways of knowing, Western approaches, and then our own Afrocentric approaches. But it's bringing those values and not assuming that the Western approach is superior, because it's actually not working for a lot of people. But it doesn't need to be thrown out, throw the baby out with the bathwater. It's bringing all these things in. And so it's really all of that. If you're able, I've seen it, you know what I mean, myself, as far as improving health outcomes. But it requires a real shift in thinking, because medicine is a very colonial way of thinking. It's patriarchal. The male is superior. The European way is superior. So I think it's really opening our minds to the beauty and the ingenuity that exists within other cultures and other voices. And so I think it's a combination of those things that you would actually see, I think, healthcare improve. Right? Ubuntu, I am because we are. If you come to my clinic and I can see your humanity and I recognize my own, why won't we find a way to be well?
Yeah, I love that. I think so much of that, I think, is such important points around like that leadership point that you make, the kind of the two-eyed seeing. We've got this phrase from my culture called anekantwad, which is around like seeing things from multiple perspectives. And I think, kind of really kind of made me think of that. And I think both within my own community of the South Asian community, but also kind of learning about what's been happening in the UK around the vaccines as well. I think there's been some positive shifts in the way of trying to, over time, realize, we need to have different ways of engaging with different people and get them involved in that. And that really kind of participatory approach just is kind of, yeah, yields kind of more inclusive and more impactful results a lot of the time. So thank you for sharing so many examples and things around that. I'm conscious that I want to give enough time for the audience to also ask some questions, and I will. There was. I'll start with one that was kind of asked ahead of the sessions. A few people had submitted some questions, and I'll also kind of look at the ones that have been coming through the chat, and we can talk through some of those. But I do encourage, if there's anyone else that's got any kind of burning questions in your mind, please do continue to pop them in the chat. I think we've got a lot of kind of nodding along through what you've said, Dr. Nnorom, like from Anne Keane, UK does not admit that racism is an issue and this must change. You know, a lot kind of resonating that things are similar in the UK. So yeah, just also kind of how important the topics are that have been raised on leadership and data from Diane. So yeah, thank you to those of you in the audience, and keep them coming. I'll ask a question around which is submitted by Eve Riley from the Richmond group. So this is: my professional interest is in the intersection between people living with multiple long-term health conditions and issues of health equity. So we know there's a big gap in healthy life expectancy when indexed by deprivation and race. But is this widely enough understood? I think the kind of answer that we've had so far is no, is possibly no. But should multi-morbidity be more explicitly linked to discrimination and disadvantage with the aim of tackling this inequity? So
yeah, so I think with multi-morbidity, I think there's actually a lot of studies. So that's why I noted yes, it is known, particularly in the United States. I mean, I think they've done phenomenal work and a great legacy of doing equity focused work. I think sometimes it gets confounded because of their healthcare system that in and of itself is built in an inequitable manner, but a really great amount of research done there. So with multi-morbidity, of course, where you have like hypertension and diabetes and hypercholesterolemia, and then you might also have mental health issues as well, which might be common, and depression and those types of things. Again, I think that's really the tip of the iceberg. And then when you look deeper to that, people are they're not able to cope, right? So there's the concept of weathering, where the everyday racism and everyday stress takes a toll over time, causing premature aging, but also the concept of allostatic load. So again, this extra stress, it's not good stress. Good stress is the kind you can overcome and you feel empowered by, but it's the stress of like, it's your skin. Like there's really not very much you can do about your skin and the race that you are assumed to be. And so what happens over time is your neuroendocrine system. So it's your hormone system, it's your immune system, it's all of these things really end up being impacted negatively over time. And so it's going to affect a number of different systems. So it's, you know, it's quite intuitive. Like if you think about the body holistically, it's just different organs that are reacting to this constant stress. And so I think there needs to be more awareness, but I think there needs to be focus on the upstream factors. And again, even as you mentioned earlier, Parita, like when we're thinking about obesity, oftentimes these are coping mechanisms. So whether we're talking about alcohol, drugs, high carbohydrate foods, and that type of thing, these are poor coping mechanisms for a really cruel way that we treat people in society, right? So we also see increased obesity rates in lower income communities. This is not a genetic condition. This is really a social condition. So I think as much as possible, yes, we need to create awareness around these different conditions, but it's really about the broader drivers that are causing these conditions to be more prevalent in groups that are socially disadvantaged.
Yeah, no, makes sense. Great. We've got a question here from Kate O'Hara in the chat. So, hi, I'm a social statistics research student at the University of Stirling in Scotland. What frustrates you about public health research, and where do you think researchers miss the mark. I know we've talked a bit about data collection, but I'm sure there's some other things as well that you've got there with that giggle you've got going on. I think this one could take a while, but yeah, over to you.
Dear. I don't even know where to start. There's so many layers to it. So I have a master's in public health. So in my training here in Canada, even just starting off, it would be being told that, first of all, in Canada, I was told by like a panel of older white males in epidemiology and biostatistics at the time, so that would have been around 2010, that that racism was not an issue here in Canada. Right, when I stood up in class to say, why aren't we collecting race-based data? And they're like, no, it's not like in the United States. And they were very condescending and spoke to me like I was slow as a Black woman bringing up these issues in this like uniformly white male, or manel as we call them. So it's the history and legacy of epidemiology and how it works, and really discrediting voices that have a different perspective. And so those perspectives, it becomes even difficult to publish the work because the power is still held by a number of these different groups. It's hard to get funding for the study. So I know that's the same thing in the US and the UK. So there's all of these barriers. Like first you're gaslighted at the beginning and kind of basically told you're crazy for thinking a problem is a problem. So that's going to affect your study, the hypotheses that you bring, your analyses, if you want to do something different, because the way it's conducted is usually problematic with a number of problematic assumptions. Then you can't get the funding, you might not be able to get the right partnerships in place, and then perhaps not even be able to publish. But even when it's published, it can be ignored, and so it's not necessarily going to create the change that you want. And so those are the challenges, but it still needs to be done. It just needs to be done in a way that I think is more in line with community organizing, activism, and anti-oppression work, which is that, first of all, even for the clinics, it's that deep listening. So listening within the groups that you're working with to really understand the issues. I was told very early on when I worked at that clinic at Taibu, any problems the community is facing, the community has the solutions. So for all of the work we did, we had to do deep listening, not that fake listening that we do as researchers and clinicians. We're like, but this is what the grant says, but I'm going to nod my head. Can you say that we, consulted with you, and then go do the thing and then publish and run away? Deep listening and understanding, and then working with groups. So yes, the publication might go out to address an issue, but now the media is ready to work with you. The communities are ready to amplify it, and you really try to kind of mobilize resources to make that change. So that's the kind of thing that I've done. So I think with that kind of research, I think it's, again, necessary, but it's not sufficient. It has to be a broad, almost like movement to actually shift things. Otherwise, it's just a publication that sits in the ivory tower, and that just gives me a bit of a rash, that type of thing. That's all.
Yeah. I think something in the chat that the social mompreneur kind of mentioned, we've got enough data in the UK, but it appears to get quickly buried. Who's leading on this in the UK and who has the bank of evidence that we can use in the first instance. And I think that's just kind of highlights that, yeah, as you say, like there's so many layers of things that need to occur, and you might get through one hurdle and then there's another and there's another, and actually just like ensuring that research has that impact in the real world for real people is quite challenging, but yeah, can be done. So then there's another question that came through earlier from Libby Papier at Mind. It's a little bit, you mentioned kind of some training that work that you do as well, but it's linked to that. How useful is cultural competence training in the context of reducing discrimination experienced in services? Is structural competence a better way forward? And maybe just sharing a little bit more about maybe some of the training work that you do and how you found that's, what's really made that work, and how has that kind of impacted on outcomes for people?
Yeah, so for this example, I'll think about what we've done at the University of Toronto and now more largely across the country with changing policies for increasing the number of Black medical students across the country. Because policy work does take a long time, and so it's there's things that we're advocating for now, but I can't kind of claim victory probably until another 1 or 2 years. So there's things we're working on now, but this is something we worked on in the past that we've seen change. So, I had mentioned what somebody does or says to another person is a symptom of the greater disease, right? And the disease is the structural piece. So, what I tell my healthcare colleagues is when we think about training people, like bias training and cultural competency training, it's important, but it's not sufficient either. It's like you have somebody who has diabetes and you treat their ulcer. Their ulcer is there because the whole diabetes is out of control. Sure, you should put dressing on the ulcer, but it is actually unethical to keep doing that if you didn't give the person insulin or medications or lifestyle changes to actually get to the root cause of the issue. And so, no, definitely those policies and structural changes. That is key. Otherwise, whatever you're training people about will continue to recur. People leave organization, like whatever is happening, you need it to be embedded in policy. And you need the right leaders in place to sustain that. And you need also probably the right expertise at the table, whether that's an EDI person and others to be at that table, as well as public accountability. Because even if you have an EDI person, that person is trying to keep their job, or sometimes there's somebody already working there who is forced to do EDI and doesn't even have the background. So the public accountability becomes key. But you have to have the structural change. So at U of T, we had, one medical student out of 250, like for years. Sometimes, there would be maybe 8 or something like that, but it wasn't sustainable. We advocated, so by we, the Black Physicians Association of Ontario, we worked with the different institutions, particularly University of Toronto, to change policies and practices. So there's a separate stream that is more culturally safe. So it's the same criteria. The criteria for entering medical school didn't change, but now there's more Black file reviewers, there's more Black interviewers, Black medical students spend time with our Black Medical Student Association. So it's the same protocol that was used before, but it's more culturally safe and there's more representation, but it's still diverse file reviewers and diverse interviewers. And we went from 1 to then 6, 16, and the last few years it's been in the 20s, having 20 or more students every year. But that came through structural change. I don't think that would have just been sustainable or even occurred with just people having cultural competence training. But I could say we did both. And I think both are good to have. I know some of my colleagues who work in anti-oppression are like, forget about the bias training and the cultural competence training, just change the policies. What I've seen in my life is an experience. It's actually good to have both. Give that insulin or metformin and the dietary recommendations and treat that ulcer and keep things moving and you see good sustainable outcomes.
Yeah. No, that makes sense. Great. We've got another question from Jenny asking about, is there any research on people who suffer from hating on their own race and culture and treat people of their own race worse than Caucasian, even though they're an ethnic minority themselves?
Oh dear. So this is internalized racism, right? And that is a factor. And I don't know that there's research. There might be on treating other people poorly, but it happens with any form of oppression. So you'll see it, like that stereotype that women just can't get along. But then I've worked in amazing organizations that are run by women and everybody is in solidarity. But it's that idea that, like, of course, when you're working for an organization where men hold the power and women have less power, then, you can only be that one woman who sits or gets the raise. Then you see that kind of tension and women might be more mean to each other than others. You see it in LGBTQ community, like you see it in so many communities, and it's a symptom of broader oppression and a poor coping way to approach it. So I don't know that there is research on that, but there is research on 2 things that are related to that. So where we talk about the term called allostatic load. So that's where you can measure indicators in the blood and body indicators of stress. And the people who work in environments where they experience racism, so they're experiencing the racism, but they perhaps hold it in, they don't actually address the oppression, and perhaps they're oppressing other people, but it doesn't speak to that, have worse outcomes than those who speak out against oppression. And so from people who are suffering and hating on their own race, odds are they're not actually addressing the root, the root cause of the oppression. And so they might be suffering in that way and have a higher allostatic load, actually. And have poor outcomes. The other example is where you internalize things like, let's say you're less intelligent, and they look at what's called stereotype threat. So you might be trying to disprove that. And often people who might be quote unquote hating on their own group are trying to prove that they're better than everybody else. And so that also has its own stress, where you see actually sometimes poor performance, actually, because you're trying so hard to overcome that stereotype. And so that's shown in like classrooms, and it's not only with race, again, it's with gender. If you tell, young women, do this math test, but, boys do better than girls, but do this, they actually perform worse because they're so stressed to defeat the stereotype than if you just let them do the exam and didn't tell them that boys did better. So I would say those are two indirect indicators that there probably is that suffering occurring. And we also know it in a patriarchal system too, that, men suffer from sexism and the machismo and the toxic masculinity, even though, they might experience privilege that women don't have, they will suffer too. So I believe it was, Martin Luther King who says, even where you have a group that is suffering directly, it affects everybody indirectly. So certainly for somebody who's having both of those happen at the same time, experiencing racism and inflicting it on other people, there's going to be a great deal of suffering, in fact.
Yeah. So there's another question that coming from Aladdin previously, and it's we've kind of talked to some of these points, but if there's anything else that kind of you have to share around it. So post BLM viewed through an intersectional lens, what are we learning which we can apply to collaborations and alliances which feel as if they've been ineffective or are underperforming?
Post BLM, was that?
Yeah, so kind of.
So we're not post BLM. Black Lives Matter. Black
True.
Lives will continue to matter, and Black Lives mattered before
No,
before 2020. But post media interest in BLM. Yes.
Hashtag. Sorry, should have said post. Yeah, the kind of media storm. Let's call it that.
No, it's fine. I just wanted to kind of point that out because I think language matters, and where we tell ourselves we're post BLM, it's like saying we're post racial. These are dangerous things to plant into our minds, right? Yeah. So it's still an issue, just not an issue in the media. I think that we have to continue the work that we were doing previously, and I think again for a lot of us we didn't have. We didn't think necessarily that the whole world was going to change because that happened. But again, there was a shift in awareness, and we need to continue to move forward. And I think there's a role for allies to play in supporting, Black Lives Matter, different activist groups, advocate groups. In healthcare, I'm sure you folks have Black and ethnic minority groups that are advocating for change. And so it becomes amplifying those voices, amplify it on social media, amplify it in spaces where, there isn't as much diversity, and say, can they come and give a talk and be paid, but come and give a talk? Can we start to move things forward? So I think we all have a role in making sure that this stays at the top of all of our agendas, because we all actually stand to benefit from living in a more just society. So I think that work just has to continue.
Yeah. We're nearly getting up, but I'm going to squeeze you in for another one. So I know you've talked quite a lot about those upstream, more like systems change and things that need to happen around, whether that's the judicial or educational or whatever. This one's more around kind of pharmaceutical companies. So, but it's a question from Leslie from VCCP Health in terms of how do you think pharmaceutical companies can help combat health inequity and racism? So yeah, I guess in that healthcare space.
Yeah, so I think, specific to pharmaceutical companies, when we look at the vaccines in particular, like the distrust is rooted in a legacy of human rights violations, cruelty, and really testing Black and other racialized people against their will, right? So I think there's that legacy to undo that. It's building trust. And I don't think that's specific to pharmaceutical companies. So for the Black Physicians Association of Ontario, our work has been to advocate, educate, vaccinate, and now we're doing rejuvenate. But the advocate was really to tell organizations that you do need to do that work of the anti-oppression training. Look at your strategic plan, bring in the right expertise. So it's a lot of the same recipe book, and then start changing your practices and do that deep listening. And it's deep listening. Like I said, listening to communities and understanding every community has a different history, a different context, a different reason for having that distrust. And it's really important to do that. And through that deep listening, one gains trust. But you need all of those pieces, and it's not unique actually to pharmaceutical companies. Those are the changes that need to happen across the board.
Yeah, great. All right. So just before we close, I guess a final kind of reflection from you on, you mentioned, that you are still hopeful. You would have obviously liked to see more change occur and things, but so tell us a little bit, like what makes you hopeful?
What makes me hopeful? First of all, it's just, I reflect on my ancestors. I reflect, on those who came before me and their struggles and how they came together in community. I think this work of resistance, like resisting status quo, and trying to maintain one's own health. So I know we were talking about how allies, but if you're affected, then you want to maintain your own health and have that resilience. It's a team sport. And so what gives me hope is these, phenomenal moments, like I mentioned, where we have our vaccine clinics, where we do this work in solidarity with so many groups who, again, are seeing the humanity in ourselves and others, and coming together to problem solve and improve the health of others, and for us to also feel fulfilled when we do that. And so those have been the beautiful moments for me of this pandemic, that type of coming together. Like I said, that Ubuntu, I am because we are. And I have hope for that. I have hope for that to continue. And I think it's much needed in medicine. And in our clinics, we had people who were, differently abled, people who were Indigenous, people who are of various backgrounds. We had refugees come in because they felt safe in that environment, right? Of course, we had our Black communities, but I think that's the beauty of it, when you can bring all these pieces together and it makes everyone feel more safe and everyone to be well is a beautiful thing. And so I hold on to that beauty in times of ugliness. That's part of why I have the podcast, Race, Health, and Happiness. It's where it's affecting you as a group. You hear all of these things about the toxicity of racism, but we're living in it. We're immersed in it. If you're Black and racialized, I love hearing about the wisdom of those who came before us and how they overcame, how we can work in community and overcome, and in our day-to-day lives, stay resilient. And those truths actually exist. They might not be in a study, but let's not engage in that kind of epistemic injustice where we only look at what's happened in the study, but the wisdom that already exists of overcoming and thriving. And so that gives me hope.
Wow. What a wonderful way to end this, really kind of fascinating discussion, and also just you sharing so much of your wisdom and passion and enthusiasm and the way that you really want to make that change for people. I think we kind of commend you on the work that you're doing. Thank you so much for joining us. Keep up the great work, and hopefully we can all kind of, as you say, in that spirit of Ubuntu, work together to kind of move forward positively. So thank you again so much for your time, Dr. Nnorom. I would also like to say a huge thank you to you in the audience for joining us. We really appreciate you showing up wherever you are in the world, whatever time it is. Thank you for taking the time out. We really appreciate it. And hopefully you feel inspired following this conversation, and stay connected to both Dr. Nnorom. Check out her work and her podcast, and also with us at Nesta in our Healthy Lives mission and beyond. So huge thanks all round, and have a great rest of the day. Thank you.